Rukhsana, you can start.
Hello, everyone, and welcome to the second half of our webinar this afternoon. Thank you all for continuing and staying on until a Friday evening. I am sure it will be worthwhile because we have excellent speakers, and we look forward to now giving you a little bit of an overview on the new aspects and the new research in pediatric PD and HD, as well as a very important talk on the availability and the specifics of different dialysis machines one needs for children of different ages. So with this introduction, it's my great pleasure to welcome Professor Klaus Schmidt from Heidelberg, who's going to give us the first talk on what's new in pediatric PD, a review of the recent literature. Thank you, Klaus.
Thank you very much, Rukhsana. Yes, indeed. This talk is not about current practice, but what is going on in research, and we'll try to look a little bit into the future, what we can expect from all these research activities for the clinical application. And I think there are many positive findings in the recent months and years, and I will give you an overview. So actually, the first slide is rather an old publication. It is from 2016, and it shows that the number of PD patients in the US is increasing again in terms of absolute patients, but also the relative number of PD patients increases. And that's not only the case in the US, but that's more or less a global finding. PD is getting more and more important. And this combined with the fact that obviously the outcome of patients on PD is improving over time. This is data from the ERK registry showing that over 5-year periods, the 5-year survival improved compared to hemodialysis. This is propensity score controlled, and we can see that over the time, the likelihood to better survive was increased with peritoneal dialysis. And here we are talking about 30 to 40,000 hemodialysis patients and 9,000 PD patients being compared. So PD is really adequate and really positive treatment. This is actually the first paper I would like to present to you. It's from Johann Morel, which is published in the PDI, and it's the ISPD recommendation for the evaluation of the peritoneal membrane dysfunction in adults. It's for adults, but I think we can learn quite a lot for children also. They recommend to perform PET tests on a regular basis. There are several reasons, and I highlighted them here in red. It's because the membrane function changes over time. We need to understand how the peritoneal membrane works, and that this impacts on our daily dialysis prescription. But they also frankly admit that whether routine evaluation of the membrane function is associated with better outcome has not been studied. Still, the author think, and I think that applies to pediatrics too, the information you obtain from a PET test is valuable for clinical practice for prescribing the PD regimen, as shown yesterday by Ariane Salosik. They come up with actually 8 guidelines. I won't go through these guidelines, I can reassure you, but I want just to summarize key findings. They define the transporter status into different categories. The one is the patient with low ultrafiltration capacity with less than 400 milliliters during the PET test over 4 hours. The other patients have fast peritoneal solute transfer rate. This can be inherited or changes in the membrane function. And the other patients have high glucose concentrations, but still low ultrafiltration due to membrane thickening and vasculopathy. And that is also what is occurring in children. So the message is classify the PD membrane and keep in mind that the faster peritoneal solute transport rate is associated with a poor outcome in adults, and that's very high-grade evidence. So it's very likely to be true that with a high peritoneal solute transporter rate, you'd have a high risk of dying. In children, it has been shown that children with a high transporter status have worse growth rates. The next recommendation is to use icodextrin because it should improve the fluid status and probably also survival. And in adults, but not in pediatric patients, usually the sodium doping is measured, so the correlate of aquaporin urine function. If it's below 5 millimole per liter, then you have ultrafiltration insufficiency. And then in the end, it's a practice point. If you have membrane dysfunction, that's self-evident. Consider encapsulating peritoneal sclerosis in your patients. That's a life-threatening event. You can die from that. Almost 50% of adult patients, 20% of the pediatric patients may eventually die from that. And consider timely transfer to hemodialysis if you have this low ultrafiltration capacity. The next paper I selected for you is on the low sodium dialysate fluids. It's a really intriguing and promising concept, reducing the sodium concentration in the dialysate and compensating for the lower osmolarity by increasing the glucose concentration from 1.5 to 2% should result in a better removal of sodium, a better control of blood pressure. There are now a few studies on that, clinical trials, but it's sort of disappointing. In this trial over 8 weeks, using in a randomized fashion the low sodium concentration or the standard sodium concentration fluids, there was no significant change in 24-hour blood pressure measurement and office measurement. Only the home measurements did improve to some extent. And the problem was that only in the patients on low sodium fluid, episodes of low blood pressure requiring medical interventions occurred. Whether this applies to children is not clear, but overall, still the concept is very promising, but not convincing. So this is something that needs further investigation in this future. The next topic I would like to address is what is the role of peritonitis in PD? We used to teach that peritonitis is a very important event, destroying the peritoneal membrane and adult patient dying from it. But nowadays, where we have very good guidelines how to treat peritonitis successfully, and in most cases successfully treat peritonitis episodes, the role is different. It is clear that with the low GDP fluids, we have a lower number of peritonitis, also with the new connection devices for the modern cyclists, less peritonitis episodes, and they are less severe with the case with balanced solution as compared to the conventional solution. And another more recent study is suggesting that the impact of the peritonitis on peritoneal solute transport is significant if the patient is on high GDP fluids. So that's what we told in former times. But there's no change in the D/P creatinine ratio when you switch to biocompatible fluids. The peritonitis episodes do not impact on solute transport, at least looking at a small number of patients here. And of course, you can ask whether this translates in peritoneal membrane transformation. So is the peritonitis resulting into changes in peritoneal morphology? And the simple answer is, in a very well-matched cohort of 4 patients with and without history of peritonitis, there's no difference in histomorphology and inflammation and cytokine invasion of the peritoneal membrane. So the take-home message is, as long as you are able to adequately and timely treat the peritonitis episode, the damage caused by peritonitis is probably not that important as we thought previously. And that's a very positive finding. Now I would like to shortly introduce the Improved PD Consortium. This is a European effort of many researchers to identify and manage patients at risk on peritonitis and to improve the outcome, especially cardiovascular outcome. One step was that integrated metadata platform was established where all the registries, all the tissue biobanks and clinical trial data and associated biobanks were unified, and metadata, so information on the parameters obtained, on the number of patients or type of patients, so is collected, and the data can be aggregated and searched for functionalities for different questions you have. And right now there are 120,000 patients collected, patient metadata collected from 41 countries, from more than 900 centers. So if there's a research question, now we have a very broad approach and can search of what is known, what has been done, what can we look at together from all these registry biobanks and clinical trials. I think that's an important step forward. One study from the group, actually run by Simon Davis in Hortra from the US, is they did a genome-wide association studies in a large number of peritoneal dialysis patients, 2,800 patients, and that was just recently published, And they thought to identify risk factors influencing the peritoneal membrane function and patient outcome. The key outcome parameter was the 4-hour DOP creatinine ratio as a measure of peritoneal solute transfer rate, as just discussed from the PET paper. The message is 19.3% of the peritoneal transport findings are inherited, so that is significant. So it's an important influence on PD membrane performance. But the other results were rather a bit disappointing. They didn't find clear genetic findings impacting on peritoneal membrane. There were only 4 loci which had a suggestive association with peritoneal transport rates, and they are associated with inflammation, fibrosis, and angiogenesis, and the term comprising all that is endothelial endothelial transformation. That is probably the pathomechanism behind these findings. But it's only suggested, and one probably would have expected more findings in view of the fact that high recoverability is 90%. But it is as it is. But there's a much more important paper that has just been published yesterday, and it goes into the same direction, trying to identify prognostic markers relevant for patient outcome. And this was done by Johan Morel and Olivier Diraboist and Simon Davis from the Improved PD Consortium. They looked at the genetic variants of the aquaporin-1 promoter. Aquaporin-1 transporting free water in the peritoneal membrane, responsible for 40 to 50% of peritoneal transport. And the findings are really impressive, and not by chance published in the New England Journal of Medicine yesterday. There's one genotype, the TT variant, which is present in 10 to 16% of the patients, depending on the cohorts. They studied the different cohorts. And these patients have a significantly lower ultrafiltration capacity and higher likelihood to die or to switch to hemodialysis. Here on the right, you can see that the TT variants, they reach the composite endpoint of death or technical failure to a much higher rate than patients who have a CT or CC phenotype. And it is interesting to see that, I'm sorry for that. The CC phenotype and T phenotype have a lower rate, and the most of the difference occurs during the first 5 years, whereas later thereafter it is not relevant anymore. So then the change remain rather the same. Another thing the study group did is they collected a lot of omics data from different tissues, and these tissues allow for very interesting analyses. And one, for example, is looking at the vessels done by Maria Bartoszova from patients on low GDP fluids, and she could really identify that the pathomechanism of vasculopathy in patients on low GDP fluids is complement activation. And of course, that is an interesting therapeutic target. And then several groups looked at the fact, does it make a difference whether we have high or a little bit lower amount of advanced glycation end products in the blood triggered by peritoneal dialysis? And the overall message is with the low GDP fluids, you have 20% lower concentration of advanced glycation end products, these very reactive metabolites in the blood. Is that relevant? Up to now, that was not clear, but a very recent paper from Bartoszova shows that yes, there's only 20% difference in blood levels. The difference in the
Klaus, sorry to interrupt you. We can't. Your slides are not moving.
So sorry, I suggest that's the next problem. So I go over to Stephanie. So whatsoever.
No, it's moving now. Okay, now it's moving. Now it's moving all of a sudden. Okay, thank you. Now it's moved. Now they're moving forward. Thank you.
Okay, so again, just to summarize, there's 20% difference in advanced glycation end product concentration in the blood when you're on low or high GDP fluids. But the much more important finding is that the number of advanced glycation end products in patients on high GDP fluid is 3-fold higher. So they do accumulate in the vessels, these advanced glycation end products, and they result in more vasculopathy. So that's a measure of lumen narrowing. If you have a low LV ratio, you have a narrowing of the lumen, and patients, and this is pediatric data, is much more important. So advanced glycation products destroy the vessels, and it's mainly disruption of junctions, apoptosis, and at the end, loss of endothelial cells with these advanced glycation end products. Then there is one study from the Vienna group asking the question, what is the impact if you use icodextrin? We heard a lot about the fact that icodextrin does improve fluid removal and patient outcome, but nobody at the moment knows what is the impact on the peritoneal membrane. And this is a very complicated study. And to make a long story short, out of many omics analysis, which were very highly published, alpha-B crystalline is upregulated in patients using icodextrin, and this alpha-beta crystalline is inducing fibrosis, angiogenesis related processes. So it's a negative finding, and this can be reconfirmed. This is pediatric tissue again in the patient. There's upregulation of alpha-B crystalline. But the good news is that the group also comes up with some intervention. Lithium can block these effects. So there's a new way of interfering with pathomechanisms in PD on the horizon. And I think another very promising perspective is to add supplements to PD fluids. This is again a study from the Vienna group, adult PD patients just published in 2018, where they had a randomized prospective crossover design. Placebo means a standard low GDP fluid, pH neutral fluid, and then the crossover to alanine glutamine or vice versa. Alanine glutamine is a diinhibitor that has shown in vivo a number of beneficial effects on mesothelial cells and also endothelial cells. And they looked for the CA125 release and the immune competence. And to summarize, the randomized prospective trial was really promising, showing that adding alanine glutamine better preserved the peritoneal membrane integrity. CA125 is a measure of mesothelial cell viability and healthy status and number of mesothelial cells. The effluent cells from patients with alanine glutamine supplemented PD fluid are more immune competent. They release more interleukin-6 upon stimulation. And in my view, the most promising finding is that adding alanine glutamine increases the semi-permeability of the PD membrane. It results in a higher D over P ratio in the PET test for potassium, phosphate, and uric acid, but the loss of proteins is lower. So this is a really positive finding, and the clinical tolerance was really good, and there's some indication that there are also more beneficial systemic effects like a reduction in circulating interleukin-8, which is an inflammation marker. And you can recapitulate these findings in vitro, and that's again a very recent paper really demonstrating that alanine glutamine is tightening endothelial cells upon exposure to PD fluids. The electrical resistance increases, the tight junctions sealing up membranes are increasing, the clustering of the junctions. And in mice model, it can also be shown that these sealing junctions are upregulated. So that's a very promising approach to PD patients. Then, of course, I told you yesterday that the glucose is still a major driver of many, many problems PD people face. And there's a lot of research on novel osmotic agents. There is carnitine and other osmotic agents currently be studied. And I just present you some data using stevia. That's the sweetener broadly used in the population. And it's a compound that has been shown to be equally effective at lower concentration than glucose and inducing less peritoneal cell infiltration and reduced peritoneal thickness and less peritoneal infiltration relative to the peritoneal thickness. This will be published very soon and showing that new compounds, this is still all experimental, but that new compounds will be able to improve outcome in PD patients. So take together, what does he want to tell you? So what do I want to say at the end? I think many of the previous publications trying to standardize diagnostics and therapy of a great value for daily routine treatment. Read and follow these recommendations. We have several pediatric clinical practice recommendations, and there's a lot of evidence that indeed these practice recommendations help to improve outcome. We're coming up with prognostic markers to predict and individualize PD therapy. I showed you the example of aquaporin-1. You can divide your population with an easy test, and I'm sure that will be introduced into clinics, looking at the different variants, whether you have a high likelihood of dying or having a loss in protein membrane function, whether you should go for icodextrin early. And we get a better and better understanding and define therapeutic targets of PD-related local peritoneal, but also systemic and especially vascular disease. For the moment, unfortunately, this understanding does result in limited clinical consequence. It tries to reduce the peritoneal glucose exposure as much as possible. Consider icodextrin in patients, especially with low ultrafiltration. There will be novel PD fluids with supplements and probably novel osmotic agents to come soon. But of course, there's still much to accomplish. You are all welcome to join the scientific groups. I thank you for your attention, and I thank you, my working group, who has contributed quite a bit to what I just presented. Thank you very much.
Thank you very much, Klaus. We will be taking all the questions at the end. So just to remind all the participants, please do send us your questions in the question section that you have, and we look forward to a discussion together at the end. So our next presentation is going to come from Bruno Ranchet in Lyon, and Bruno is going to tell us about what we should take into account before buying hemodialysis machines. Thank you very much, Bruno.
Okay. You can see my screen?
Yes, yeah. Thank you. We can see it clearly. Thank you.
Sorry. Okay. First of all, I would like to thank the organizer for giving me the opportunity to speak about what we should take into account before buying hemodialysis machines. I have no conflict of interest to declare. We are working in my unit with Fresenius 5 and 6008, Baxter PrismaFlex Prismax, and Medtronic Carpe Diem devices. Before to speak about hemodialysis machines, I have to remind the need of use ultra-pure dialysis water. To get ultra-pure water, we need a water treatment station with water softener, charcoal and small sieving coefficient filters, and double reverse osmosis system. The dialysis water circuit and dialysis machines need regular disinfections with regular controls of dialysis water, dialysis bath, and substitution fluid. Other important questions to ask before to discuss of machines are: is the unit exclusively pediatric? If it is an adult and pediatric unit, choice of machine is shared with the adult nephrologist. How many people in the medical team? How much medical time is spent on dialysis, on hemodialysis? How many people in the paramedical team? Are they working only in the hemodialysis unit or also in a conventional or day hospital or consultation ward? How much biomedical time is dedicated to hemodialysis devices? How many children on chronic hemodialysis? The more your means are limited, the fewer children you have to dialyze, the more difficult it will be to have several types of hemodialysis machine. Are you working in collaboration with a pediatric or neonatal intensive care unit? Which machine is used to do CRT? And who is in charge of hemodialysis in these units? Last but not least, the most important question to ask is, which children do we need to dialyze? particularly children of which age and which weight. Most pediatric centers will have to take care of children from 0 to 18 years and 1 to 100 kilograms of weight. You can see in the table the proportion of different weights in children on hemodialysis start. Thus, in my center during the last 14 years, 15% of hemodialyzed children weighted less than 10 kilograms at dialysis start. In the ESPN registry, including children 0 to 15, you can see that 12% of children weight less than 10 kilograms and 45% less than 20 kilograms at dialysis start. In the IPHN registry, an international registry comprising a majority of European centers, and patients aged 0 to 121, 6% weight less than 10 kilograms and 24 weight less than 20 at dialysis start. Small children, therefore, represent a significant proportion of children on chronic hemodialysis. Most of us have to dialyze both in acute and chronic setting, and in most cases are implicated in CRT program in collaboration with intensive care teams. Guidelines recommend that the extracorporeal volume must be less than 10% of blood volume, and therefore less than 10 milliliters per kilogram before 1 month of age and 8 thereafter. In fact, we have learned in clinical practice that, although it is by no means perfect, children tolerate extracorporeal volume of up to 16 mL per kilogram if they do not need ultrafiltration. What was the line volumes in the old good time? Gambro offered a 32 milliliters lines on ERK 200S, and both Fresenius and Nikizo a 56 mL lines on 4008 and DPB07 devices. These machines are no more available in Europe. You can see on this slide lines volume in the 2021 chronic hemodialysis machines. The dialyzer priming volume must be added to this line volume to get the extracorporeal volume. The smallest dialyzers available are Gambro Polyflux 2H, 17 milliliters, and Fresenius EpicSped, 18 milliliters. It enables to see the extracorporeal volume in this column. You can see in the last column the theoretical minimal weight with each device and each lines. Two companies still propose pediatric lines. Baxter offers on ERK 98 a baby line of 36 mL and two pediatric lines of 85 and 100 mL. And Fresenius an 83 milliliters lines on 6008 and a 108 line on 5008. You can see on this slide the extracorporeal volumes achieved with adult machines and the theoretical minimum weight with each machine on each line in the last column. Thus, according to the recommendations on line volumes, dialysis of children under 10 kilograms is only possible with Baxter ERK 98 and neonatal lines. Nevertheless, in daily practice, during the last 14 years, we have been able in our center to dialyze on Fresenius 5008 with 120 25 mL of extracorporeal volume, 11 children weighing less than 10 kilograms, 4 weighing less than 8.5 kilograms, 2 of them 7.6 kilograms, and thus in these 2 children with an extracorporeal volume of 16.4 mL per kilogram. All had residual diuresis. As I told you, they represent 15% of patients, and more than half suffered from oxalosis. You can see on this slide the Fresenius 6008 sets. When you compare pediatric and adult sets, you can see that the lines inside the pump are identical. The difference is in the lines outside the pump, which are thinner in the pediatric set on the left of the photography. Regarding the baby lines of the ERK device, the lines are both shorter and thinner inside and outside the pump. The team of Robert Debré Hospital in Paris dialyzed with this device a child weighing 6.6 kilograms after PD failure. The guidelines recommend a blood flow of 150 to 200 mL per minute on 1 square meter of body surface area, keeping arterial pressure above -200 millimeters of mercury and venous pressure below 200 millimeters, and recirculation less than 10% if catheter and 15 if arteriovenous fistula. Which blood flow can we get with these low volume lines? The maximum blood flow with the ERK98 neonatal lines and the 6008 pediatric set is around 80 mL per minute for the first and 90 for the second, because higher blood flow increases arterial pressure below -200 millimeters, and venous pressure above 200. This max blood flow is higher with 85 milliliters ERK98 pediatric set. We know that the lines are not the only limiting factor. Vascular access also limits max blood flow. 110 mL per minute with Medcomp 8 French tunnel catheter in Europe. This limit could maybe slightly higher with BARD glide path 7.5 French tunnel catheter available in US. These are the smallest permanent catheter available. Could CRT machines be used for chronic dialysis of the smallest? You can see extracorporeal volume of different CRT machines. Among neonatal devices, Carpe Diem has get FDA and CE certification. Nidus is not yet commercialized. As you can see, adult CRT machines have quite low extracorporeal volumes, especially Infomed HA440 and Baxter Prismaflex Prismax. Which blood flow can we get with these CRT machines? Nidus machine is a fully neonatal device with extremely low blood flow, enabling use of single lumen central venous line. Carpe Diem is designed as adult CRT machines, but with miniaturized lines and a 3 rotors blood pump. It enables to use 5 French catheter as vascular access in the smallest and higher blood flow than with NIDUS device. Adults device unable to reach blood flow allowed by small permanent catheter. Which maximum dialysate and substitution flow can we get with TC-ERT machines? In chronic hemodialysis, dialysate flow rate is recommended between 1.5 and 2 times blood flow rate, and probably at least of 300 mL per minute. Carpe Diem provides 10 milliliters per minute of dialysate or substitution flow, fluid flow, but not simultaneously. Adult devices deliver 67 to 25 mL of dialysate per minute and 33 to 8 mL per minute of replacement fluid. These dialysate flows are 5 to 20 times lower than dialysate flow used in chronic hemodialysis devices, but may nevertheless enable to do intermittent dialysis in the smallest. Ultrafiltration and fluid control must be extremely precise in the smallest. It is easy to see that the maximum ultrafiltration target of 10 mL per kilogram an hour is 15 times greater in a 60 kilogram teenager than in a 4 kilogram kid. You can see ultrafiltration accuracy of different devices. This imperfect accuracy can be a problem with the smallest children. CRT machines alarms when ultrafiltration deviates from the target. You can see it is fluid accuracy. Most devices, in most cases, this accuracy is given in mL per hour, with when it is indicated dialysate flow of 300 to 500 mL per minute. Some firms give it as percentage of ultrafiltration. Moreover, fluid control must be maximum in optimal situation, but also in case of vascular access dysfunction or ultrafilter leak. You can see 2 safety warnings issued by the 2 largest companies regarding the risk of excessive ultrafiltration in the event of catheter dysfunction in small children. This risk appears to be reduced with the new software versions of the 2 devices. This imperfect control of fluid accuracy justifies that the companies limit their liability when their devices are used in small children and do not seek regulation authorities' agreement for the smallest. You can see on this slide agreements requested and obtained for the different devices. And you can see the weight for each devices. Carpe Diem 2.5 to 10 kilograms. And you can see Fresenius more than 5 and 6,008 more than 10 kilograms, and the other more than Nikizo more than 20, and Baxter more than 25, Brown and Nipro more than 30 kilograms. Is dialysis with a single needle possible, and with which lines and which volume? ERK 98 and Fresenius 6008 enabled single needle dialysis with lines volume of 140 to 190 mL, but in both devices, not with the lowest volume lines. In 6008 machines, single needle dialysis is not possible with low volume software dedicated to children weighing less than 40 kilograms. Other devices need lines volume around 200 mL. The 6000 device allows, with an adult kit on normal volume setting over 40 kilograms, to switch during the session from the double needle system to the single needle during a session without changing line. Sorry. This is okay. Pardon. Which machines offer the possibility of doing online hemodial filtration? This is a weak point of the ERK98, which is designed to be an easy-to-use home dialysis machine. Which substitution flow can we get? The goal in post-dilution is at least 23 liters by 1.73 square meter. In pre-dilution, the goal is at least 33 liters per square meter and 75 to 100% of blood flow. In post-dilution, the substitution flow is optimized by an automated system in 5 devices, which make it possible to achieve less than 28% of the blood flow rate with the Nikizo DBB XA device, and a little better, around 30%, with the 2 Fresenius and Baxter Artist machines. We have no data about substitution flow obtained with Niprosurdialix. In pre-dilution, the substitution rate is manually set on Nikizo DBB XA, Baxter Artist, and Niprosurdialix. It can be set manually or managed automatically with the Fresenius 5 and 6008 machines. Concerning 6008, Fresenius manual setting do not enable to reach the target, and the automated management is not optimal, often less than 75% of the blood flow, but sometimes as high as twice the blood flow. Which machines are able to monitor patients during sessions by blood flow volume follow-up and online clearance measurement? Again, this is a weak point of the ERK98 machine. Some new generation adult machines enable also to evaluate vascular access with circulation. But all these measures are only possible if the blood flow is more than 100 mL per minute, and the 6008 machine manual indicates that the optimal blood flow is 250 mL per minute, and that all these measurements are only validated in patients weighing more than 40 kilograms. Concerning the urea distribution space, it is calculated by devices with Watson formula, which is not suitable in pediatric patients, and must be replaced by Morgenstern's formula. Nikizo DBB XA and Fresenius 6008 devices allow the return of blood without disconnecting the lines, but not in pre-dilution online HDF mode with 6008. The Fresenius 6008 device can monitor and control sodium exchanges during sessions and can perform isonatric dialysis if desired. But sodium control is only feasible in patients weighing more than 20 to 40 kilograms. In summary, the bad news is that the good old days are gone, with fewer and fewer dialysis machines with pediatric lines. The good news is that the dialysis machines available for adult patients are getting better and better, but with insufficient adaptation and often, if not always, without validation in children. Thus, these machines are used off-label by pediatricians in many children. How to choose? We must first know and assess the performance and characteristics of each machine. Second, we have to take into account the agreement of the regulatory authorities for the weight. Third, we have to adapt the machine as much as possible to the weight and needs of the child. Fourth, we have to take into account the ability of our team to use more than one device. Last, we need to collaborate among pediatric nephrologists, between pediatric and adult nephrologists, between pediatric nephrologists and intensivists, and last, between pediatric nephrologists and industrial partners, in order to better know the qualities and limitations of each machine, in order to choose the one most suited to the need of our patients. Thank you for your attention.
Thank you. Thank you very much, Bruno, for an absolutely excellent talk and overview. This is so important for anyone working in pediatric dialysis or wanting to set up a new dialysis unit. That was brilliant. I have to do the next talk now, so I will move on to sharing my screen in a second. Stephanie, can you see my slides?
Yes, we can see it.
Oh, good. Thank you very much. Okay, so we've just heard from Klaus about what's new in pediatric PD, and I'm going to follow on with a talk of what's new in pediatric hemodialysis with a review of the recent literature. I'll talk to you about a little bit about vascular access and then about intensified dialysis treatments, including daily and nocturnal HD and hemodiafiltration. So yesterday we spoke a lot about vascular access, and this is really the Achilles heel of HD. If you have good access, you have good blood flow, and therefore every attempt must be made to improve access. This very recent and interesting article has come through from the South Korean team. And here they compare plastic cannulas versus metal needles in the initial use and cannulation of AV fistulas. This is a study in adult patients, and the mean age of the population is about 60 years, but it's still something very important that we should consider for our children as well. My study of incident HD patients with 45 patients per arm. They use metal needles versus plastic cannulae, and their primary endpoint was initial cannulation failure rate, which is defined as the failure to successfully complete 3 consecutive dialysis sessions. This shows the types of the needle and the plastic cannula used, and also the size of them. And this shows their randomization. So after AV fistula creation, they perform a Doppler ultrasound, confirm access patency and blood flow rates, and then the first needling is performed. This was at approximately 7 weeks post AVF formation. And you see that the patients are randomized 1:1 to receive the metal needle or cannula. And then they look at the first, second, and third needling to define their endpoint. So here are their results in a summary slide. The percentage of patients with cannulation failure was higher in those with a metal needle as compared to plastic fistulas. and the time for cannulation success was actually better with plastic cannula. So the same data presented somewhat differently, giving you the time to failure with the two different devices. Here we see that the patient's pain score in these first two bars, the pain score is much seems to be higher with a plastic needle compared to, with a plastic cannula compared to a metal needle. And the cannulation difficulty for the nurses is shown here. And fortunately and luckily, the dialysis efficiency and the KT/V is higher with a plastic cannula. So these data tell us a little bit more difficulty with a plastic cannula, but still something that can and should be considered, provided we get adequate size cannulae for our pediatric patients. Moving on to clearance, and yesterday Fabio and Evelyn spoke a lot about clearance on HD and PD and the molecular size or molecular weight of the molecules. So you see here this graph, which shows a kind of sigmoid relationship with very low molecular weight substances like urea and creatinine over here. Down here. This is very funny. Sorry about that. Okay, so low molecular. Okay, sorry. Low molecular weight substances like urea and creatinine at the bottom end of the graph, and as you go higher, you see substances such as IL-8, TNF-alpha, IL-6, all inflammatory markers, of course. You also see beta-2 microglobulin, which is considered a prototype middle molecule, and its accumulation over many years can lead to amyloidosis. We also see other substances, alpha-1 microglobulin, alpha-1 acid mucoprotein, etc. And we know that substances associated with pruritus on dialysis, associated with joint pains and amyloid accumulation, and with EPO resistance are all middle and large molecular weight substances, and these require clearing on dialysis. So in other words, clearance of low molecular weight substances is really easy, and therefore when we monitor urea reduction or we monitor creatinine clearance by KT/V, to be honest, that's not such a big deal. More and more so, the focus is now going on middle molecular weight substances and their clearance. And of course, clearance of these middle molecular weight substances is more efficiently performed by hemodiafiltration, where you have convective clearance as well. Here we see 4 randomized controlled trials performed in adults, and this is from the HDF European Pooling Project. There are 4 independent studies with over 2,700 patients in total, and individual assessment of studies as well as pooled metadata from all of these shows a significant benefit of HDF compared to HD. And very importantly, from these studies, sorry, my slide advancing is going a bit funny. From a combined cumulative assessment, which is called the UDIAL pooling project, we see that the hazard ratio for death shows a strong correlation with the convective volume achieved. So in the study in green here, which is the Eschol or Spanish study, we see that they achieved the highest convective clearance, and as a result, they had the lowest hazard ratio for death. So there are important things for us to learn from this as pediatricians. One is that convective clearance offers very good outcomes in adult patients from their RCTs. And second, the convective volume is important. The blood flow through a dialysis access, of course, is one of the key determinants of convective dose. And therefore, we need to see if HDF is feasible in children and if it does indeed have good outcomes as well. With this in mind, we performed a pediatric prospective observational study. We called it the 3H or the HDF Hearts and Heights study. And here our outcome measures were children on HDF compared with HD have an improved cardiovascular risk profile, improved growth and nutritional status, and an improved quality of life. We've looked at a number of different aspects of comparing HDF with conventional HD. So that means HD performed 3 times a week in hospital. And we see and I will describe to you the cardiovascular outcomes, blood pressure control, bone disease, growth and nutrition, and health-related quality of life. So one of our key outcome measures was cardiovascular outcomes. And of course, in children, fortunately, we do not have hard outcome data such as death or myocardial infarction. And therefore, we use the best surrogate measures available. The carotid intermediate thickness standard deviation score is measured by high-resolution ultrasound of the common carotid artery, standardized for age and sex, and then presented here. So you will see data in red for HD and in blue for HDF, and with baseline and follow-up data for all patients. Now here, this is described as standard deviation score. So of course, you know that a standard deviation score of more than 2 is abnormal. And at a glance, you see in this graph that a large number of our patients have an STS above 2 for a carotid IMT. So there's already prevalent cardiovascular disease in our cohort. At baseline, there's no difference between HD and HDF cohorts here. But you see that in the 1-year follow-up, patients on HD had an increase in their carotid IMT, whereas in the HDF cohort, this was almost static. And this suggests to us that HDF may attenuate the progression of IMT change. The IMT increase in the HD patients was almost half a standard deviation, which is an extremely large increase in a short period of time. The factors that affected a higher or influenced a higher IMT on multivariable regression was the HD or HDF group, a higher interdialytic weight gain and ultrafiltration rate, suggesting a volume effect on IMT, and therefore similarly, of course, with the blood pressure, but also a higher beta to microglobulin influenced this. And this is really important because it suggests that both volume as well as clearance on HDF both play a role in this. Moving on, we looked at blood pressure control, and we looked at this in both a cross-sectional and longitudinal fashion over a period of 15 months. As a important, unique part of this study, this is the only study on HDF, which has looked at, even compared to adult studies, which has performed 24-hour mean arterial pressure, mean ambulatory pressure monitoring. So we had ABPM monitoring in all our patients. And of course, this is so much more important than a single pre-dialysis blood pressure that most other studies look at. And again, you see at a glance that the SDS is above 2 for a large number of patients, and certainly for all the patients in red here who are on HD. So virtually all patients on HD have a blood pressure above 2 standard deviations, at least the average. And on HDF, you see that the blood pressure is comparable at baseline, but then reduces and then remains low for the duration of the study, such that on longitudinal analyses, blood pressure continues to increase on HD and remains static on HDF or does not progress. And here the factors that affect the blood pressure increase are the dialysis modality and the interdialytic weight gain. Looking further, so this slide has kindly been given to me by Klaus Schmidt from the IPHN network, and in their network, they looked at more than 930 patients, all pediatric age, with over almost 2,800 observations. These patients, 64% had HD, about a quarter had HDF, and of these intensified dialysis, either HD or HDF was performed, sadly in a small number, but hopefully this will get better. Very interesting to see that the dialysate sodium is in fact perhaps quite high. So it's the average is 138 millimoles a liter, but going to as much as 145 millimoles per liter. And of course, the increased blood pressure was in a remarkable number of patients, with 62% of children on antihypertensives, with up to 6 antihypertensive agents in some. Now, very interestingly, the diastolic blood pressure SDS, as well as the interdialytic weight gain, were both influenced by the dialysate sodium. And the dialysate sodium predicted both of these factors on a multivariable analysis, suggesting that we have a fairly simple modifiable risk factor that we can adjust and reduce as appropriate in order to improve blood pressure and therefore reduce interdialytic weight gain. We also have talked a lot about growth on HDF. And in fact, many of you will know these excellent data from Michelle Fischbach's group in Strasbourg, where they show fantastic growth on HDF and also amazing catch-up growth and increased growth velocity. But importantly, Professor Fischbach performed high convective volume pre-dilution HDF with up to 5 days a week or 18 hours of dialysis per week. So this is combining intensified dialysis and convective clearance, and also a large number, if not all, the children were on growth hormone. So which of these factors, and perhaps all of them, contribute to improved growth? In our HDF study, in our 3H study, all the children were on 3 times a week, in hospital HD or HDF. And you see here that the height SDS is low, so it's below 0 and below -2 standard deviations for lots of children, and the height remains static over 1 year in the HD cohort, but actually increases somewhat in the HDF cohort. We looked at the factors influencing improved growth, and here we see that despite more children on HDF being on growth hormone, there was no difference in height SDS in the growth hormone treated HD and HDF patients. So this is interesting, but there are relatively small numbers. Perhaps we need more analyses into what factor it is that makes these children grow. Interestingly, there was an inverse association between the height and the beta-2 microglobulin. That means the lower your beta-2 microglobulin, the better your growth. And I don't think beta-2 microglobulin, I'm quite sure beta-2 microglobulin itself does not influence height, but it is a marker of middle molecule clearance. And there are perhaps some other middle molecules that are actually being removed by HDF and therefore perhaps permitting better growth. So we have a lot more to explore in terms of what this might be. We went on to do a post hoc analysis of bone formation and resorption ratios. So we looked at bone-specific alkaline phosphatase, which is an osteoblastic marker, and the TRAP5B, which is a tartrate-resistant acid phosphatase produced by osteoclasts. So in other words, we are looking at the enzymatic activity of osteoblasts versus osteoclasts. And when we perform a ratio of these, we see that in the HD cohort, the backtrap ratio actually decreases in HD over 1 year, but increases in HDF over 1 year. So in HDF, there's more osteoblastic activity and bone formation. We, again, data from IPHN, thanks to Klaus, looks at the analyses of the different factors that may predict catch-up growth in their registry. And in this analysis, there are 330 incident patients with sort of maybe one third or 1/4 of them on HDF, and a follow-up of about 1.5 years. And you see from this analysis that significant predictors of improved growth are the HDF modality compared to HD, the baseline height of the patient, and also the blood flow. So important factors determining this. And when you go on to look at a multivariable analysis of the same cohort of the same data, we see that the HDF modality and the height SDS significantly predict improved and catch-up growth. And of course, again, to stress, both of these are modifiable risk factors, so something we can implement in all our patients. There's excellent editorial from Franz Schaeffer described the anabolic effects of daily HDF. And of all of these factors here, from appetite improvement, correction of metabolic acidosis, minimizing inflammatory cytokine release, and possible release of somatomedin and gonadotropin inhibitors by HDF, and reversing growth hormone resistance are all potential hypotheses. Remember, this has not been studied so far, and it requires further study before we know if this is in fact the mechanism whereby improved growth occurs in HDF. Another interesting factor was looking at the fibroblast growth factor 23 and the circulating Klotho levels. And here you will see again that FGF23 levels decrease. So this is the percentage change over 1 year, and they reduce substantially. In fact, below zero, reduced by 25% in HDF, but increased by over 110% in HD. Now, this is fairly simple to understand. FGF23 is a middle molecule. It will therefore, of course, be cleared by HDF, whereas it continues to accumulate in HD. Interestingly, serum Klotho there's no change whatsoever between dialysis modalities. But when one looks at the FGF23 Klotho ratio, you see that it's substantially lower in HDF and up to 3.8 times lower. And this is again interesting because FGF can have multiple off-target effects, most importantly on cardiac myocytes and cardiac hypertrophy. Moving on now, let's look at inflammation. So we know that dialysis induces inflammation. And here we looked at a number of inflammatory markers, including interleukin-6, TNF-alpha, high-sensitivity CRP, and then fetuin A. And fetuin A is an inverse inflammatory marker, so it's the opposite of CRP. And you see this slightly odd thing where the HDF patients have lower inflammatory markers already from baseline compared to HD patients. And this is seen in all of these different measurements. So the baseline varies, which is very strange. But when you keep in mind that baseline in a dialysis patient is in fact after 1 month of dialysis, and all baseline is defined as post after 1 month. So we performed a separate study called the switch study, where we switched patients from HD, high flux HD, for 3 months to high flux HDF, keeping all other dialysis parameters static. So the dialysis machine, the filter, the blood flow rate, and the water quality were all controlled, and only the modality, so convective clearance, was applied. And what we see in this study is that in a 3-month period, with just 3 months on HDF, there was a higher antioxidant capacity, reduced inflammation, improved endothelial function on all these different measurements. And so very sensitive markers of endothelial damage within a short period of 3 months change and improve on HDF. This effect was seen in patients irrespective of those who had residual renal function, and even those with residual renal function had a decrease in beta-2 microglobulin and therefore improved clearances by HDF. So now let's come to perhaps the most important factor for our patients. Why do my slides not move again? Sorry. Yeah, sorry. So let's look at nutrition and growth. And just Fabio, 1 minute, sorry. Okay, so my colleague Fabio Paglialonga, who spoke yesterday at the meeting, has done this subgroup analysis with us, post hoc analysis, looking at factors influencing growth and nutrition. And here we look at diacylghrelin, a factor for anorexia, and we see how it has reduced in 3 months on HDF from baseline to 12 months. He looked at adiponectin, a marker of protein energy wasting, which is also reduced in HDF and is also strongly correlated with the height standard deviation score in both these analyses. And finally, the IGF-1 standard deviation score, which in fact improves and is associated with an anabolic effect. So these factors are very interesting. They require a little bit more analysis, and we hope that we can find some explanation for why our children on HDF grow better and why many of them report a better appetite. So with this, we come to what is the single most important thing for all our patients, which is how they feel on dialysis. And we asked our patients to complete a 6-monthly questionnaire reporting how they feel on HD or HDF. And you see in the top row here that headaches, dizziness, and cramps were all reduced in frequency and in severity on HDF compared to HD. In contrast, you see that factors such as sleep disturbance, pruritus, and restless legs are not different between the two dialysis modalities. So in other words, factors that relate to fluid or volume control are better on HDF as reported by our patients. And in fact, this was associated both with the ultrafiltration volume per session, so that we know that driving ultrafiltration too hard with a high UF rate is not good for our patients, and they do feel more miserable with it. Another factor on dialysis is something called the post-dialysis recovery time. So this is basically asking patients, how soon after a dialysis session do you feel back to normal? And you see in blue that the post-dialysis recovery time is very low, even 0 or a few minutes in HDF, and it is considerably higher in red in the HD patients. And interestingly, this correlates with their physical activity score and their school attendance as well. So here to summarize our findings from the on HDF versus conventional HD, we see that in children, HDF holds the progression of vascular changes compared to conventional HD. It is associated with an early and sustained improvement in fluid status, reduces inflammation and oxidative stress, and improves endothelial function. These changes occur early in the time on dialysis, and so even those with a short dialysis vintage would do better on HDF. Children on HDF had a small but significant increase in their growth, in their height, and in their bone formation. Again, an important factor of anabolic processes improving on HDF. And most importantly for the children, their quality of life was better. Now, HDF is one form of intensified dialysis, but first to most importantly add, none of this data is randomized, and we do need a randomized study in children before we can make definitive conclusions about the benefit of HDF. So HDF is one type of intensified dialysis therapy. And of course, intensification can be either at home or in center. It can be with increased frequency or daily or nocturnal, with the duration on time on the machine, the day or night time, and the modality of HD or HDF. So lots of different ways to intensify it. And we know that there's a long list of advantages of intensified dialysis, many of which I've shown you already. Home hemodialysis can in fact add a great deal more advantage in some situations where where the restrictions on diet and fluid are removed, medication burden can be reduced, and of course, home dialysis can be performed anywhere. But it is not for every patient. It does have disadvantages. The carer burden and the patient burden is huge. The home is converted into a kind of hospital. The utility bills are large. We know that using a fistula every day can cause damage to it, for long hours can cause damage to it. And it needs a great deal of commitment from the child and family. Therefore, this survey from the Berlin group was performed through the IPHN registry, asking all the participants, which dialysis modality do you believe offers the best overall patient outcome? outcome. So this, all physicians from 134 different centers were asked what they believe is best. A large number, of course, indicated intensified HD, some indicated PD, and some HDF. Very interestingly, this is what they believe is good, but what do we actually achieve in real life? And again, this slide from the IPDN registry from Klaus shows that only 38% of centers in 2017 were able to offer intensified HD or HDF in their patients, and a number of barriers, including a lack of funding, shortage of staff, and a lack of expertise and motivation, were quoted. However, hopefully these numbers are going to increase and improve over time, and at least more patients are now performing HDF and more are performing intensified dialysis. Let us hope these numbers can continue improving. So in conclusion, I've shown you several different studies, but when you look at it and actually analyze the quality of the studies very rigorously, we see that a lot of the information comes from registries. These are international registries. They do include large numbers of patients, but sadly, they are still only registry data. When you think about the quality of data in different types of studies. Also, we have a number of retrospective studies, again, often small numbers. And the 3H study is a prospective observational study, but importantly non-randomized. And therefore, as pediatricians and pediatric nephrologists, we really must try and do better and develop RCTs to have an evidence base for our practice. I'm going to stop with this, but just do a little bit of advertising to tell you again that we have a course on advances in pediatric dialysis. This follows on from the course we held last year at the same time. It's all on Zoom on the 10th and 11th of February, and we invite you all to attend, please. So thank you very much, and I'll now hand over the chair to Klaus to lead our Q&A session. Thank you, Klaus. No?
Can you hear me?
Yeah, we can hear you. Can't see you yet, but we can hear you. Ah, there. Okay, Bruno, hi.
So,
perfect. Thank you, Klaus.
I'm just looking whether there are questions in the chat. So one question is, from which age can we use, first of all, Roxana, thank you very much for this brilliant overview. I really appreciate it. A little bit too much Klaus Schmidt, but otherwise wonderful. Thank you very much.
He's a famous man.
No, come on. From which age can we use AV fistula in children in your experience? Roxana, I think that is really a question addressed to you. What would you suggest? When could we start, at what body length or body weight to insert fistula for chronic hemodialysis?
Thank you. So this is, as you say, it is not based on age, but much more based on size. And to be very specific, of course, it's based on the size of the vessels rather than the kind of size of the child or weight of the child. Another extremely important factor is surgical expertise. And we are fortunate to have very experienced surgeons here, as well as I know the surgeons in France may have amazing AVF success rates as well. The smaller the child, the more challenging it is, of course, and it is the creation of the fistula, but equally importantly, the needling and the success with blood flow rates. We do have fistulas in children even as small as 10 kilos in size. This is the lowest limit we have in our experience, but fistulas in children of about 15 kilos would be fairly routine in our experience.
Yes, I would definitely agree. It depends very much on the surgeon, but if you have an experienced surgeon, you can start from 15 kilograms onwards. Another question repeatedly asked, Roxana, is, of course, it's all our decisions are transplantation driven. What would you think is the time interval of expecting the transplant, which would rather suggest to put in a CV line?
It's so important. important again. There's no easy answer to this, and certainly no evidence base to this, but as we have recommended together in our ESPN guidelines, we suggest that if there's a living donor kidney transplant likely to happen in the next 6 months, then we would say keep on a CV line. But if there is if the child will need a deceased donor transplant and goes on to a waiting list, then of course this depends entirely on what the average waiting time in your country is and how sensitized or not your patient is. And really, if there's a likelihood of more than 6 months before transplantation, then we do recommend AV fistulas. This is not this is not an absolute recommendation, but knowing that that the CVL change is frequent in children, and one can go through multiple CVLs, damaging central vessels. This is the recommendation from ESPN.
Yes. And another question would be, I mean, you have shown so much data on the advantages of hemodiafiltration over hemodialysis. Unfortunately, at least many European countries are now able to realize hemodiafiltration. Is there any indication to maintain a patient on standard hemodialysis when the HDF option is given by the machine in the dialysis center?
Extremely good point, and I would say no to that. So, really, the important thing to stress is that one needs ultra pure water, very high quality water for HDF. This is actually a one-time installation cost for your unit, and thereafter the cost of HDF is not greater than HD. Another important thing to remember is when we all use high flux filters or dialyzers these days, a high flux filter will have some degree of backfiltration, which means that there's a mixing of the dialysate water with the blood, and therefore a risk of endotoxemia or even low-grade inflammation. Therefore, using high flux filters even on HD does require ultra pure water. So really, the HDF, the only patient I would leave on HD, provided you have these other criteria met, are the very small ones, the very young ones, below 10 kilos, where they cannot have the appropriate filter and the benefit of HDF, where you do need a slightly bigger size. Again, irrespective of the time or the dialysis vintage that you expect, and irrespective of residual renal function, we have shown that HDF has better outcomes than HD.
Thank you very much. And there's a question for Bruno. Bruno, if you have only one choice for one machine, which machine would you choose for chronic hemodialysis in children? What would be your recommendation?
I think it's a big question. I can tell which choice we have done. We have done to buy half of our machine as 6008 to keep IOP as long as it will be possible, half of machine 5008. And we are planning to use CRT machine, Baxter Prismaflex and Prismax now, to dialyze eventual smallest children, less than, I don't know actually the limit, probably less than 7 kilograms, and carpe diem for the smallest one. It's a choice we have done, but it's sure that's not a perfect choice. I think we have a lot of work to do with industrial partners to validate all these machines and to evaluate these machines in pediatric setting. It has poorly done, and I think there is a lot of work to do. I hope my answer.
There's another question going into the same direction. You have an infant of 5 kilograms needing chronic renal replacement therapy. Which machine would you recommend? CarbiDiem, Informate HF 1 in 40? Or what would be your recommendation at this point?
in the last 10 years, we didn't have the problem, but it's sure it's quite the limit. I think the limit between Carpe Diem and Prismax is around 6 kilograms, and because I think there will be a big problem, because the big problem will be the access. We have only access of 8 French, tunneled catheter of 8 French, no smallest. Then I think the limit.
The very practical question is: you have a child of 5 kilograms, and you have the choice of Carpe Diem or the Infomate HF 440. Which one to choose?
I think the problem will be the vascular access, and
okay. Rather than the machine.
We have first used Carpe Diem, but in some children around 6, we have first tried to do dialysis with the 5 French catheter, but it was only not tunneled catheter because they don't exist, and we have now a child in the intensive care unit which we move from Carpe Diem. She's 6.3 kilograms, and we move from Carpe Diem and 5 French catheter to Baxter Prismax and 6.5 French catheter. But sure, we will be. It will be difficult if we need to continue the hemodialysis because of the vascular access. And you have seen the slide in my presentation. Our friend from Paris, Robert Debré, was obliged to switch from PD to hemo, a little girl of 6.6, and they have used an 8 French tunnel catheter, and they are dialyzed this child on AK 98. I think the big problem will be the vascular access.
Okay, thank you very much, Bruno, for this comprehensive answer. And then there's one question regarding aquaporin 1, whether aquaporin 1 is definitely the target for the future to reduce ultrafiltration and membrane failure. Are there any pharmacological studies? And the answer is yes. Actually, Olivier Devoist had shown a few years ago, published in JASN, that there are compounds which can increase aquaporin 1 activity. And there are several other groups, including my group, looking at the molecular correlates behind what we call the 3-pore model. The 3-pore model is just a model, and we are studying the junctions, and the ultimate aim will be to modify these junctions to increase, for example, phosphate removal, because that is a huge limitation in peritoneal dialysis, phosphate removal. And this will go from identifying the targets of interest to in silico studies on what could be the compounds to increase it. And then, of course, the huge question will be, are they clinically applicable? What is the tolerability of these compounds? Another approach would be to supplement PD fluids with aptamers, which bind phosphate, because when binding to an aptamer, the gradient between dialysate and blood is maintained during the trial. So there are quite a few very interesting things going on in this field. And I think the last question, and then we come to our clinical case, is again for Ruxana. Is cardiac insufficiency or heart transplantation a contraindication to AV fistula?
No, I don't think so. Not to my knowledge. So we don't really see the Steele syndrome in children. It's more reported in adults, and it's, I think, related more to peripheral vascular disease. But we've rarely ever seen in children. So I would not preclude that. I would not exclude it at all. In fact, a heart transplant patient is likely to be sensitized. They may have a longer waiting time to transplantation. So I would, in fact, actively advocate having a fistula in them. Klaus, may I ask you a question?
Sorry. A patient who has actually heart failure, so reduced heart output rate.
So sorry, I didn't hear you. Sorry. Sorry. So heart failure. No, again, I would not discourage that at all. We have not seen Steele syndrome in any patients, and not seen this complication. I would in fact ask, is the heart failure related to chronic volume overload? Do you therefore need to remove volume, improve blood pressure, optimize ultrafiltration? And that might in fact be achieved by HDF better than by HD, as we've seen in our study.
Okay.
May I ask you a question, please?
Yeah, sure.
Sorry. No, you finished. Sorry, I thought you were going to close the session. Sorry.
I couldn't hear you, Riksana. Could you please repeat your question?
Okay. No, I thought you were about to close the session. So my question is, in your talk, you showed very nicely that this substance alpha beta crystalline accumulates in PD patients, and I just wanted to check: does it accumulate more with low GDP fluid or with icodextrin?
It's specific to icodextrin. So that's a new pathomechanism just related to the use of icodextrin. And we have very, very few data on the clinical tolerability and membrane tolerability of icodextrin, because every patient has one daytime dwell only with icodextrin and the other solution. So it's hard to discern, but it's for the first time we could demonstrate that this could be a difference and clinically relevant at the end. But it's still experimental. So So thank you very much. In the interest of time, I think we should now move on. We have one clinical case, which will be presented by Annika Gold, and it's a few slides, and I think interesting case which we could discuss then. Thank you very much, Annika.
Oh. I think you can you see me, Noah? Yes, there we go. Okay, oh, sorry. So, I am Annika Gold from Heidelberg. Would like to present one interesting clinical case of a girl. Sorry, need to move on with the slides. Okay, yeah. So we have a 14, I think she's 14 years old, a girl with a diagnosis of steroid-dependent nephrotic syndrome. I'll just talk about the genetics in a minute. It's a long story. So the onset of the disease started in 2009 when she was 2 years old, with a first symptoms of her nephrotic syndrome with a mildly decreased GFR, and then a very complicated clinical course with many relapses. So we counted 22. I'm sure there was more because she was kind of auto-treated by her parents, and she always had she got better with prednisone, but she didn't have a complete remission. And she was put over the years. She was put on several immunosuppressants, cyclosporine, tacrolimus, MMA, and rituximab. She had a second hit in 2013 when she developed an atypical hemolytic uremic syndrome, which necessitated some days of, I think, acute hemodialysis. Most likely, this was tacrolimus associated. And then in 2017, she got diagnosed with focal epilepsy, a mild form, and valproate was started. And then over the years, the GFR declined. And then in 2021, she had a very severe relapse, and she ended up on becoming hemodialysis dependent with a GFR of about 8 or 10. And throughout the years, we performed several genetic exams. And in 2018, we found a NextMyth gene mutation, actually a somatic mosaicism, 13% affected cells. And the NextMyth mutation is, so NextMyth is an abbreviation of murid extension and migration factor. So it's a transcription factor that is well known in the family of X-linked mental retardations. There are normally those patients have intellectual development disorders and epilepsy forms of various clinical degrees. And mostly it's males affected, but there are also some affected females due to X inactivation. And there are other organs that are infected, that could be affected too. And some patients actually they present with serodependent nephrotic syndrome. That's what we found in her. And so what do we have? So we have this 14-year-old patient, 42 kilograms, body surface of 1.3 square meters. She is on her dialysis therapy plan. On the left is it's HDF, so it's HDF 3 times weekly for 4 to 5 hours. She has a good working arterial shunt on the left forearm. We're performing double needle hemodialysis. She's got a standard coagulation. She has our standard dialysis machine, the FX 5008. She has a good arterial blood flow of about 180 milliliters per square meter per minute. She has a very good convective flow of 107 milliliters per minute, or the volume of 18 liters per square meters, and this equals out as an KT over V of 2. And still, this patient remains anemic. So she has a mean hemoglobin level of 75 or 7.5 to 8, and she remains very low on albumin. So she's got values of 19 to 22 or something, despite transfusion of human albumin at the beginning of each dialysis. And despite, let's say, extensive research, the girl is pretty much, she has a minimal urine production left of about 100 milliliters per day. There is no sign of intestinal disease, such as celiac disease or something, and there are no protein losses via the stool. And still, she remains anemic, and she has this reduced serum albumin in her blood, despite sufficient dialysis, despite no known losses. And so we are not sure why. Would like to pose the question into the audience and ask if someone has an idea, someone has seen the same case. Any ideas?
Did you dose a protein in the urine?
Yes. So it's a bit difficult because she has a mild mental retardation, and she's not, so she has an involuntary loss of urines. The last time we checked, she had 100 milliliters per day left. Yeah? And she had, I think, 1.5 grams or something, but can't be a lot because it's just 100 milliliters a day. Yeah? So
Anika, if she doesn't have a big urine loss, and as you've shown there isn't a gastrointestinal loss, then is this a liver synthetic function problem? Is she
no, there's no sign of liver dysfunction. No hepatomegaly, no that everything's okay. No. So
and when you give her albumin, you said you prime the circuit with albumin. Do you prime it with 20% albumin or 4.5% albumin?
We calculated at about 5%.
5% albumin. Okay. So suppose you did prime it with 20% albumin, assuming that you do have a good ultrafiltration. Yeah, you have to confirm that your access is perfect, that you are not stuck with 20% albumin in the circulation and no sort of removal mechanism on dialysis. If you do prime with 20% albumin, perhaps you can improve her serum albumin with that, and then you could almost measure the degradation of albumin from giving and improving her serum albumin towards normal levels, to how quickly that albumin in her circulation drops. Would that be helpful to see how quickly it degrades, and then try and work out, is this all coming out in her urine quickly, or is there more stool loss, or is there some sort of albumin degradation in her system for whatever reason?
I don't think we did that yet. So we didn't transfuse her, until her values were normal, and then we didn't check how fast it goes, how fast it declines. I don't know, we didn't do that yet.
I would propose to do nephrectomy because I think maybe you can underestimate the renal losses, and it will explain that she do not answer to erythropoietin. There can be a losses of erythropoietin in the urine in the nephrotic children, and I would propose to use more frequently the erythropoietin, maybe to switch to sorry, erythropoietin B or A, and more frequently. And I would propose to do a nephrectomy because I think the proteinary losses are underestimated.
Okay.
We can calculate the protein losses. Let's say it would be 1 liter. It could be 10 grams per day, but if it's only 100 to 200 milliliters, the absolute amount of protein loss is not high. And actually, we primed the system with 5 grams per liter of albumin. So we gave a sort of albumin transfusion, and this sort of increased the serum albumin levels. And we stopped that for a short time before. But in my view, I doubt that the kidney is really the point. I don't know what the problem is, but overall, my hypothesis is, and that is what I would like to share with you, is this child had a partial response to immunosuppression, and she has seen a lot of immunosuppression over time with different compounds. And at some point, she got renal insufficiency. And you know, you measure creatinine in blood, and then you do all these calculations of renal function by the known Schwarz equations and so on. And you measure cystocin, and you come up with 4 different results of the calculated estimated GFR. But as a matter of fact, the creatinine depends on the muscle mass. And the second point is that the fact that she's been losing within few months her residual renal function suggests that we put her on dialysis rather late than early. Of course, everybody wants to prevent dialysis and hope for some immunosuppression. In my view, the resistance to hemoglobin, despite different compounds and a very high dose therapy, the resistance to normal synthesis of albumin could be related to a long-term toxic therapy combined with CKD at the end being very severe, with the GFR estimated of 10, but probably being lower than that because overestimating the GFR. And my hope is that with adequate and intensified hemodialysis, the things improve a bit. So we have a convective flow of 80 milliliters per square meter, high KT over V. But the truth is, of course, we placed the fistula. We started with single needle dialysis. As you know, it's only now that we really come up with a high and very efficient HDF. So my hope is that the child will improve. The hemoglobin started to increase, but it's a slow process, and we could stop the human albumin infusions. He has no edema at the moment anymore. For me, the lesson is, first, sometimes we tend to underestimate the decline in GFR, and the patient goes to dialysis rather late. And the combination with immunosuppressive compounds has an additional toxic effect. And this is what we have to keep in mind. But I'm not sure whether this is the true answer to it. It's my hypothesis, which I'm happy to discuss with you.
She doesn't have any copper deficiency?
Or what kind of deficiency?
Copper. Copper, sorry.
So she's been to the ophthalmologist.
If you plan to do a transplantation, I think you will have to do a bilateral nephrectomy before. Then I think it will be good to try if it enables to increase albumin level, blood albumin level.
But just to get it right, I mean, if there's no urine output anymore and she will have very little output soon, she oliguric already, why should we do nephrectomy?
because it will enable you to do a diagnosis of relapse earlier.
Okay, that's the point.
And I am sorry, but I will be very sure that there is no more losses in the urines, because I think for me that's the first thing to be sure that's not the case. And it will
but Klaus, sorry, I was just saying, I think both of you are saying something similar. You want to be absolutely sure that this is urinary protein loss before you do something reasonably drastic like a nephrectomy. And even a small residual kidney function is still of some value, as we have learned from adult studies. So perhaps actually, even if required, admitting her and having a catheter which sounds a bit extreme, but it's not as extreme as a nephrectomy, to monitor all her urinary losses over a 48-hour period. And 48 hours is important because her urine output will alter on the hemo day and non-hemo days. And then seeing how much actual quantitative protein loss there is. You could also, measure her thyroxine binding globulin and immunoglobulins to see if she's losing other proteins in the urine as well. And then a nephrectomy could perhaps at this very low GFR even be a chemical nephrectomy. She's already on ramipril. You could increase, as long as she's not hypokalemic, increase the dose of ramipril, and you might achieve a chemical nephrectomy without major surgery.
That's a good point. I mean, we could quantify by putting in a catheter, and yeah, I agree with that point. That's a good point. There's some comment from the chat by Eduardo Laporta. He asked whether we measured pre-albumin. Did you perform a nutritional status assessment? The answer is no. It's a really good point. We didn't do so far because she has a really good BMI and the appetite has increased via dialysis again. So we didn't think that it's a nutritional intake problem, but of course at some point, if we don't improve with the high convective flow hemodialysis filtration for extended period of time, we should really do so. I agree, that's a really good suggestion. Thank you very much. Any further suggestions from the audience or from Bruno and Roxana?
Klaus, just out of interest, unfortunately, it's not a suggestion, but a curiosity. Atypical HUS is quite rare. So are you suggesting that this girl has 2 or 3 different rare diseases in her?
I mean, we think it was tacrolimus related. It's not an complement is.
Oh, sorry, I missed that.
It was very closely related to tacrolimus therapy, and it was resolved.
So, but that was a very severe relapse, and she ended up on hemodialysis for a week or something.
And the PTH is controlled? You don't have any problem with PTH?
Target range, yeah. But I think you made a very good point, Dr. Ronchard, because we actually, a week ago, we put her on Aranesp, so we changed. Huh? We stopped the Mircera and we put her on Aranesp, and her hemoglobin level has gone up by 2, no? Or 20, no? So now she's on 10. So you might be right.
I think it's argue for higher losses in the urines, because it's quite common in nephrotic syndrome to need we need one dose after one daily dose in some children, because there is erythropoietin losses in the urines.
Okay, that's interesting.
I think that's very valuable, and I'm happy to hear that it's 10 now. It's really good news. And Bruno, I think your point is very well taken with PTH. There's a lot of data showing that severe hyperparathyroidism reduces erythropoietin sensitivity, and parathyroidectomy, on the other hand, an adequate treatment can improve erythropoietin sensitivity. So I think we have a lot of good information, a lot of good suggestions. I thank you very much for all your input. And Roxana, do you want to close the workshop?
I can, but I think Justine, if you're online, do you want to say some final words?
Yes, I'm online, but can you hear me? Because I had some
Perfect.
problems during the first
Yeah.
session. So
We can hear you well. Thank
Great. So it was a fascinating session. Thanks to all of you, the three of you, the 3 stars of dialysis. And I really would like to thank all the speakers from yesterday and today, because I think it was very lively and very interesting. I hope that the attendees agree. Please send us your comments or suggestions for maybe organizing a new workshop next year on these kind of topics. And thank you so much for being there, and enjoy your weekend if you have a weekend. And see you very soon. Take care. Bye-bye.
Thank you. Bye, everyone. Thank you.
Bye-bye.
Bye-bye.